Good morning. I'm Dr. Sabitha Gokulraj, reader from the Department of Oral Medicine and Radiology, Vinayaka Mission Sankaracharya Dental College. The topic for discussion is on ameloblastoma. Before we go on to ameloblastoma, let us learn about what odontogenic tumors are. Odontogenic tumors represent a spectrum of lesions ranging from malignant and benign neoplasms to dental hematomas, all arising from the odontogenic residues, either from the epithelium or from the ectomesenchyme, with variable amounts of dental hard tissues formed. Occasionally, an odontogenic tumor develops from a pre-existing developmental cyst or a dental primordium, or in many instances, exact tissue of origin of the odontogenic tumor, which may only be inferred from its site and structure. According to WHO, the odontogenic tumors are classified into benign and malignant, with major subdivisions in each category. Under benign, we have the odontogenic tumors arising from the odontogenic epithelium without odontogenic ectomesenchyme. The examples being ameloblastoma, squamous odontogenic tumors, calcifying epithelial odontogenic tumors, adenomatoid odontogenic tumors. The second category being odontogenic epithelium with odontogenic ectomesenchyme with or without hard tissue formation. The examples are ameloblastic fibroma, ameloblastic fibrodentinoma, odontoameloblastoma, calcifying odontogenic cyst, complex odontoma, and compound odontomas. The third category are the odontogenic tumors arising from the odontogenic ectomesenchyme with or without included odontogenic epithelium. The examples are odontogenic fibroma, myxoma, and cementoblastomas. Under the malignant category, we have the odontogenic carcinomas and the odontogenic sarcomas. Under odontogenic carcinomas, we have the malignant ameloblastoma, primary intraosseous carcinomas, clear cell odontogenic carcinomas, and ghost cell odontogenic carcinomas. Under odontogenic sarcomas, the examples are ameloblastic fibrosarcoma, ameloblastic fibrodentinosarcomas, and ameloblastic fibroodentosarcomas. The ameloblastoma is a true neoplasm of enamel organ type tissue which does not differentiate into a point of enamel formation. The term ameloblastoma was suggested by Churchill in the year 1934 to replace the term adamantinoma, which was coined by Melasses in the year 1885. It has been described very aptly by Robinson as being a tumor that is usually unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent. Ameloblastoma is the second most common odontogenic neoplasm, and only odontoma outnumbers it. Going on to the pathogenesis of ameloblastoma, the ameloblastomas have a varied origin, although the stimulus initiating the process is unknown. Thus, the tumor conceivably may be derived from cell rests of enamel organ, either remnants of dental lamina or remnants of Hertwig's sheath and the epithelial rests of Melasses. It could either arise from the epithelium of the odontogenic cysts, particularly the dentigerous cysts and odontomas. Disturbances of the developing enamel organ are either from the basal cells of the surface epithelium of the jaws. It is also thought to erupt from the heterotrophic epithelium in other parts of the body, especially the pituitary gland. Ameloblastomas are of three types. The first being the conventional solid or multicystic, which accounts to about 86% of all the cases. The second category, the unicystic, which accounts to about 13% of all the cases. The third, we have the peripheral or the extraosseous ameloblastoma, which accounts for 1% of all the cases. Now, let us discuss the clinical features of ameloblastomas. Ameloblastoma has a wide range of occurrence of the tumor from 10 years through 90 years of age. The average age at diagnosis being between 33 to 39 years, and most cases have a cluster between ages of 20 and 60 years. Only about 10% of the cases have been reported to arise in children, and less than one-third of those occur in children younger than 10 years. There is no significant sex predilection, but it's thought to be reported to have an increased incidence of ameloblastoma in Black individuals. Ameloblastomas occur in all areas of the jaws, but the mandible is the most commonly affected area. More than 80% of the cases are present in the mandible. And within the mandible, the molar angle ramus area is involved 3 times more commonly than the premolar and the anterior regions combined. It is also found that the maxillary tumors tend to occur in a slightly older patients than do the mandibular lesions. The radiographic features of ameloblastoma is unique, and it can represent itself either as a unilocular radiolucent lesion or a multilocular radiolucent lesion. Most typically, the radiographic feature is that of a multilocular radiolucent lesion. And if it is multilocular, the lesion is often described as having either a soap bubble appearance or as an honeycomb appearance. If the loculations of the radiolucent lesions are large, it is described as soap bubble appearance, and if the loculations are small, it is termed as honeycomb. In the radiograph which is showed here, large multilocular lesion which involves the mandibular angle and ascending ramus is shown. The large loculations show the soap bubble appearance, and unerupted third molar has also been displaced high into the ramus. The buccal and the lingual cortical expansion is frequently present with ameloblastomas. It is most of the time associated with the resorption of the roots of the teeth adjacent to the tumor, which is very common. The radiograph here shows a uniform radiolucent area with resorption of the roots of the anterior tooth. Going to the histopathology, histologically, the ameloblastoma shows neoplastic proliferation of the odontogenic epithelial cells, mostly in distinct patterns. 6 histopathological subtypes of ameloblastomas are recognized. They are follicular type of ameloblastomas, plexiform type, acanthomatous type, granular type, basal cell type, and desmoplastic type of ameloblastomas. Of these varieties, the most commonly encountered variant is the follicular type of ameloblastoma. The basal cell type of ameloblastoma is considered to resemble the basal cell carcinoma of the skin, is thought to be the rarest histological subtype. Going on to the treatment of ameloblastomas, the patients with conventional solid or multicystic intraosseous ameloblastomas have been treated by a variety of means. They either go in for a simple enucleation and curettage, or they go into an en-bloc resection. And if it is an en-bloc resection, a radiographic clearance of about 1 to 1.5 centimeters beyond the tumor size is usually advocated.